Good afternoon, all of you guys. Sorry for the technical delay. It was caused by computer malfunction. So we talk about diastolic function today. And a quick introduction to diastolic function starts with the pressure volume loops. Those who are talking, would you be able to sort of stop talking now? Thank you. Now it's gone. Okay. So the two phases of the cardiac cycle that we are interested in are the isovolumic relaxation period, marked by the closure of the aortic valve and the opening of the mitral valve. And as you see, it's a steep decline in the ventricular pressure without a change in volume. When you have cases of significant mitral regurgitation or aortic regurgitation, that's not a good representation of what is happening, because there will be volume change along with the change in the pressure. Then we have the filling phase, which is between the mitral valve opening and the mitral valve closure. In a normal heart, ventricular pressure drops fast, can be characterized by the time constant of LV relaxation. And the ventricular rise in pressure with filling of the ventricle is a process that results in good LV filling, fast LV filling without much of an increment in filling pressure. This is sustained in the presence of exercise in healthy individuals, even with faster heart rates. We can characterize the stiffness of the ventricle or the distensibility or compliance of the ventricle. These are terms that can be used by looking at what happens to the volume and pressure as you alter the venous return. The way this is done is by decreasing the venous return gradually by inflating a balloon in the inferior vena cava. And then you look at the end diastolic pressure-volume relationship. This approach is called the multiple cycle approach and is the gold standard. It can be done using a single cardiac cycle, but this is the more accurate approach. We can talk later about reasons for that. Let's look at what happens in a normal heart with exercise. And as you see, with exercise, the heart rate goes up. When you look at the 75 watt stage of exercise, you can see ventricular systolic pressure goes up, but look at the minimal pressure. At baseline, it's about 0. With exercise, it becomes subatmospheric. And why is that happening? This is happening because the rate of relaxation increases. This shows the first derivative of LV pressure, and this is the dP dt that is positive. That's the negative one with exercise, and you can see that it has increased to more than 400 millimeters mercury per second. So that faster relaxation is what is allowing for the minimal pressure to drop and what is maintaining good LV filling despite that fast heart rate without an increment in the left atrial pressure. In comparison, in a diseased heart, this is what happens. So we're looking here at the ventricular pressure in green, and the end diastole is marked by that dotted green line and systole by the dotted blue line. And at baseline, you have a minimum pressure that is around 1, very close to 0, a normal EDP about 11. This individual with marked diastolic dysfunction ends up with very modest upper extremity exercise, having an increment in LV systolic pressure. The scales are different to allow for recording of higher pressures, but look at the minimum pressure. Way off that 0 millimeters mercury, and the end diastolic pressure is 30. The patient had to stop because of shortness of breath. So we've contrasted now the normal and the abnormal hearts. Let's look at the pressure volume loops. Mr. Tyree is around. And this is the pressure volume loops in a patient who has non-cardiac dyspnea. If you look at the end diastolic pressure volume relationship, it's a straight horizontal line. Even though the end diastolic volume is varying a lot from the maybe 130 all the way to the 170, the end diastolic pressure doesn't change it almost much. or minimally, if any. In comparison, this is a steeper relationship at end diastole, showing a rise in ventricular pressure that is steeper with the change in ventricular end diastolic volume taken from a patient with heart failure preserved ejection fraction. So before we delve into the non-invasive criteria, good to know what are the invasive measurements that we call for, that we would want the non-invasive measurements to tell us. So these include the time constant of LV relaxation, more than 48 milliseconds, and end diastolic pressure more than 16 millimeters mercury, increased chamber stiffness constant, and then increase in the filling pressures with exercise. If you use the end diastolic pressure, the cutoff is 23. If you use the wedge pressure, it's 25. Where these numbers come from, these come from normal individuals who exercised, and they looked at the mean +2 standard deviation values. Granted, the data used to come with these numbers are small because you do not typically subject healthy individuals to cath to get these data, and these are also older studies. Another approach that has been adopted is to look at the ratio of the wedge pressure to cardiac output and how it changes with different stages of exercise. And you would have a steep slope in someone with heart failure preserved ejection fraction. This is not a definition that is universally accepted. So now when we record ventricular pressure, these are the pressures that we see. We have the lowest pressure in the ventricle, that minimal pressure that I showed you early on. With opening of the mitral valve, ventricular filling takes place, ventricular pressure rises, and it further rises at end diastole when the left atrium contracts. There is a plateau phase in the ventricular pressure before its pressure rises in end diastole. That is referred to as the pre-A pressure. It is possible to measure the pre-A pressure. It is also possible to measure what is called mean LV diastolic pressure. It's a mean, temporal mean for all the pressures that you record in diastole. To get to the mean and to get to the LV minimum pressure, you need a high fidelity pressure catheter. End diastolic pressure is easily measured in the cath lab, though it varies with respiration and typically is taken at the end of expiration. How about atrial pressure? Atrial pressure, we see the V-wave pressure at end systole. That's the highest pressure in the atrium before opening of the mitral valve. That is called the first crossover point, where ventricular and atrial pressure are similar. Afterwards, ventricular pressure drops below the atrial pressure because the ventricle is relaxing, resulting in a small pressure gradient shown here in blue that allows for filling in the ventricle. So typically the pressure gradient is established first and then flow takes place because of inertia. So the peak flow rate does not happen here, but happens a little bit later. And the same with atrial contraction. We have a rise in atrial pressure. And then with atrial relaxation, we have a drop in atrial pressure. That's the X descent, that's the Y descent, which happens because of flow leaving the left atrium and pressure dropping. We have a mean left atrial pressure as well, and the mean is less than both the V and the A wave pressures, and usually is also very close to the LV pre-A pressure and to the mean wedge pressure, as well as the mean LV diastolic pressures. Where you will have differences between atrial and ventricular pressures are in patients with mitral valve disease. Example from a patient with hypertrophic cardiomyopathy, marked degree of diastolic dysfunction. You see a minimum pressure that is way elevated, a pre-A pressure of 24, a huge rise in the A wave pressure with atrial contraction, and an EDP in the 30s. Word of caution when we measure pressures, say the wedge pressure, which we rely on a lot, you want to get a good pressure waveform. A good pressure waveform for a patient who is in sinus rhythm is to see A and V wave pressures as you see in these simultaneous LV, LA pressure recordings. In comparison, a balloon that is just advanced and hitting the wall of the artery but not in a wedged position would result in a falsely elevated wedge pressure that can have significant implications in how a diagnosis is reached and how a patient is evaluated. So now that we've established the invasive piece, let's look at the non-invasive piece. The two parts that we rely on, or the two big signals that we rely on, and they are not the only signals, mitral inflow and annular velocities. These are recorded by pulse wave Doppler with the sample volume at the tips of the mitral valve, and we have to record at the tips. It is not in the funnel, it is not at the annulus. We have flow in early diastole. As you see, it follows that pressure gradient, and we have flow in late diastole, A for atrial filling, E for early diastolic filling. In a normal heart, the E velocity rises fast, so a short time needed to accelerate, and it decays fast, what we call a short deceleration time, a ratio that is more than 1, E to A, and a short time interval between the closure of the aortic valve and the opening of the mitral valve. That's the isovolumic relaxation time. With impaired relaxation, left ventricular pressure drops at a slower rate. As a result, the pressure gradient is less, the E velocity occurs, but with a lower value, slow increase in the velocity, slow decay, so long acceleration, deceleration times, and the atrial contribution to ventricular filling is more. If you would, the atrium before its contraction has more blood because little emptying or less emptying has happened in early and mid diastole, and that triggers a more forceful LA contraction by the Starling mechanism, giving rise to that A wave, assuming that the atrial contractility is still preserved. The isovolumic relaxation time is prolonged because one of the determining factors for the opening of the mitral valve is the pressure gradient, and that pressure gradient is reduced in the absence of an increase in LA pressure. If LA pressure increases, and this can happen as a compensation sometimes to worsening diastolic function, to faster heart rate, or with fluid administration, say indiscretion with salt and fluid intake, we have again predominant filling in early diastole, a ratio more than 1, short isovolumic relaxation time, and short decel time. With successful treatment of that volume overload status, we can see it reverting back to that pattern. This pattern is referred to as the impaired relaxation pattern. That pattern is referred to as pseudo-normal if the ratio is less than 2. If more than 2 is referred to as restrictive filling. But before we label someone as pseudo-normal or restrictive, we have to ascertain that this is an abnormal heart, and that filling pattern would then have that connotation. Annular velocities are also recorded by spectral pulse wave Doppler, but here at the tissue, at the level of the mitral annulus with tissue Doppler, the emphasis is more on the lower velocities, higher amplitude signals. And so we've set the filters to exclude these higher velocities of flow across the mitral valve, and we have a small recoil during isovolumic relaxation, then early diastole and late diastole. With impaired relaxation, the early diastolic recoil velocity is reduced with a bigger contribution for a late diastolic velocity. But with progressive deterioration of diastolic function, rise in filling pressures, including end diastolic pressure, as you nicely see in this example, the end diastolic pressure now is exceeding atrial pressure. A prime velocity is reduced and the E prime remains reduced. So this is an interesting finding, or important, not just interesting. Why? Because even though the E goes up, the E prime remains reduced. So it has a different response to the change in filling pressures in the setting of myocardial disease that allows us to rely on the E prime. There are data to show that the E prime velocity is related to the left ventricular relaxation. This is pressure taken, this is the time constant of LV relaxation measured by a high fidelity pressure catheter, and we see here the E velocity measured at the base of the posterior wall. With longer relaxation, longer time constant, the E velocity is reduced. So there is a significant correlation that you see here. That was a R value of about 0.7. now that we've established that E prime is related to velocity, to the relaxation, the question, or the more important question of how does it change with the change in the transmitral pressure gradient should be addressed. Because if it behaves the same way as mitral E, then E prime velocity doesn't add much to us. And this is taken from a experimental study, taking dogs and then infusing dobutamine and esmolol to enhance and suppress relaxation. And it shows the transmitral pressure gradient measured by catheters in the LA and the LV. If you look at the stages where relaxation was relatively preserved, time constant less than 50, shown here in the solid circles and the straight line, the annular early diastolic velocity is directly related to the transmitral pressure gradient. So in normal hearts, if you increase the transmitral gradient, if you increase LAP, the annular early diastolic pressure, the transmitral gradient goes up and the early diastolic velocity goes up. In comparison, in stages where relaxation is impaired, shown here by the open circles and that interrupted line, you can have a decent variation in the transmitral pressure gradient, and that's a very large difference that you see here at the extremes, with little change in the early diastolic velocity. So in diseased heart, it is not that much affected by the transmitral gradient. The reason it is not affected by diseased heart is it becomes delayed, and it happens during the second crossover point when the two atrial and ventricular pressures are similar to one another. Similar data, but shown here in humans, with variable degrees of diastolic dysfunction, variable in flow patterns from impaired relaxation all the way to restrictive. You see a wedge pressure that varies from 5 to more than 40s, with no relation between the early diastolic velocity and the mean wedge pressure, similar to what you saw in the animal studies. And so that takes us to the introduction of the E to E prime ratio, and that's the rationale for it. We say that the mitral E velocity is directly related to left atrial pressure, and we know that it's inversely related to the time constant of LV relaxation. So then we have the expression of E being directly related to the ratio of LAP to the time constant. Since we know that the time constant relates inversely to the early diastolic velocity by tissue Doppler, we can remove that time constant and put in its place 1 over E prime. And so E becomes directly related to the product of LAP and the early diastolic velocity. Since the interest is estimation of LAP, then we rearrange that expression and we end up with that ratio that has no units, both are in centimeters per second, that relates to LAP. So now let us talk about day-to-day application of these principles to assess diastolic function. It is important to look at a lot of data, not just on the velocities. And why? You can have velocity values that fall in the normal range, but they are occurring in a diseased heart. As we were talking earlier, that would have a different connotation if you're looking at a normal heart versus a diseased heart. So you need to know the clinical history. You need to look for evidence that tells you there is structural heart disease, like ventricular hypertrophy, seen in patients with significant degrees of aortic stenosis or patients with hypertension. So hypertension is important to know from the clinical history. We need to look for other indicators that there is structural heart disease in patients with hypertension, for example, left atrial enlargement. And then abnormal LV systolic function. And here we do not just rely on ejection fraction, we look at LV long axis function, best captured by LV global longitudinal strain. Showing you examples of strain in a normal heart and in a patient with heart failure preserved ejection fraction. We can assess strain, as you've heard in previous presentations, in the circumferential direction and in the long axis direction. The one that goes down first is that longitudinal direction. And if you look at the normal heart, it's minus 18%. In this patient with heart failure preserved EF, circumferential strain relatively preserved, but this is markedly reduced at 7%. And as you are aware, that metric is associated with subsequent adverse cardiovascular events. So it's important to look for it. We also can look at the torsion of the heart, the twisting motion that happens because of the base and the apex rotating in opposite directions. And you see here global strain from a patient with heart failure preserved EF reduced in that four-chamber view as well as on the polar map. And if you compare the normal with the patient with heart failure preserved EF and the patient with heart failure reduced EF, you can see that during systole, the twisting motion is preserved in the heart failure preserved EF, but not in the patient with reduced EF. And if we look at the first derivative of twist, and now we're looking at twisting rate during systole and diastole, again preserved in the heart failure preserved ejection fraction, but not in the patient with heart failure reduced EF. The problem with that heart, despite the preserved untwisting rate, is that untwisting is delayed. You want the untwisting to occur earlier to contribute to the drop in ventricular pressure. On the other hand, if it occurs later on, then it is happening at a time when the left atrium now has to have a higher pressure to allow for LV filling. Sometimes or many times we look at hearts that have a normal ejection fraction. You look at everything that we've talked about and it looks as though there is no apparent disease. So here we need to rely on some other signals. Pulmonary veins are very useful. And the yield of pulmonary veins should be in excess of 90% in the outpatient setting. Inpatient setting depends. Is the patient ICU, instrumented or not? But if somebody goes carefully after it, you can get high quality signals. This is taken from a patient with heart failure preserved ejection fraction. The one we are interested in is that atrial velocity that happens in late diastole. When the left atrium contracts, its pressure increases, and so it will force blood either through the mitral valve into the ventricle as well as back into the pulmonary vein, because now left atrial pressure exceeds pulmonary venous pressure. When LV late diastolic pressures are elevated, the flow tends to be abbreviated, as you see here, short duration and also very small A velocity that decays fast, short decel time. In comparison, there is not much of a resistance for the blood to go back into the vein. As a result, you have a velocity that is much higher value and of a much longer duration. We compare the time difference between these two signals, mitral A and the atrial velocity in pulmonary veins, and a time difference exceeding 30 milliseconds is indicative of increased LV and diastolic pressure. Also, a velocity in late diastole in the pulmonary veins, that A reversal that exceeds 35 centimeters per second, is associated with increased LV and diastolic pressure. Valsalva maneuver is very helpful. If you take a patient who has an increase in their left atrial pressure and they go through the forced phase of expiration with increase in the intrathoracic pressure, venous return drops, including into the left atrium, which drops the left atrial pressure, which drops the transmitral pressure gradient. Now you have a mitral inflow before Valsalva at baseline where E exceeds A. And notice it's now an impaired relaxation pattern. If a patient can cooperate and perform the Valsalva, this is a very useful tool to look at and diagnose the presence of elevated filling pressures. It is specific, but is not that sensitive, and the challenge comes for patients who are intubated, who are short of breath, who cannot cooperate for other reasons. Also, good idea to look at the tricuspid inflow. In the lab, part of our protocol is to acquire tricuspid inflow. Let's take a look at these pressure recordings taken from the left ventricle and the right ventricle from a patient with cardiomyopathy. If you look here, ventricular diastolic pressures, pre-A or end diastolic pressure, are elevated, and you have restrictive filling on mitral inflow. On the other hand, if you look at the RV, pre-A, and end diastolic pressures, they are normal. Because this is not a normal heart but a diseased heart, you have a reduced E velocity relative to A velocity. If we take the pressure signals away and we're looking at a heart and we know that it is a diseased heart and we see this discrepancy, this should raise the concern that left atrial pressure is indeed elevated, because we know this connotes a normal right atrial pressure, so it's a diseased heart. That pattern should have looked similar to the tricuspid inflow. The reason it doesn't look like it is because of the elevated pressures. L velocity is a velocity that signifies flow from the atrium to the ventricle in mid-diastole, and it is happening because relaxation is still taking place. Normally, relaxation is complete in normal hearts in early diastole, but in diseased hearts, it can even extend into late diastole. And it also happens because the left atrial pressure is exceeding left ventricular pressure with a slow heart rate. If you have a velocity that 50 centimeters per second or above, that's another indicator of impaired relaxation with elevated LAP. 20 centimeters per second or less can be seen in normal hearts, in the setting usually of slower heart rates. You can also notice it sometimes in the tissue Doppler signal. But we rely on the mitral inflow, not the tissue Doppler signal. Now, if we've gone through all of these and we are paying attention to all the signals that we are getting, but then we cannot yet make a determination whether there is or there isn't diastolic dysfunction, we go to that chart and we look for the E prime velocity, the average E to E prime ratio, peak TR velocity. We have to acquire TR from multiple windows, use agitated saline if indicated, or make, if you give ultrasound enhancing agents, go back and record the TR velocity, because it is helpful, as you see, for diastolic function and also to report PA pressures. And then biplane LA maximum volume index. The majority of the signals fall in the abnormal range. There is diastolic dysfunction. If the majority fall in the normal range, normal diastolic function, in between, if you have 2 out of 4 signals or 1 out of 2 signals available and they are discordant, then it's indeterminate diastolic function. Word of caution about LA volume. To get a good LA volume, you do not rely on the same location of the transducer which gets you the large LV volume. Frequently, we need to go to a higher intercostal space, and that will foreshorten the ventricle, but will show you the true LA size. When we scan, that's what we have to do. It's not the same position that will give both. Otherwise, we will foreshorten the LA, underestimate LA volumes, and that causes problems.
Is that 34 normal value? Is that based on?
That's based, this is not necessarily based on LA focused views. It's based on data that has been published that related mean plus 2 standard deviation values. The assumption is that whoever scanned in these studies was careful and did their best to show the LA volume. But it is not explicitly stated that it is relied on these views. Now we know that the upper limits of normal LA volume very likely are more than 34 milliliters per meter squared, up to even 38 or 39 mLs per meter squared. This is using echocardiography. And so if we have 3 variables available, that's okay, we can still use them. And if the majority are abnormal, we call diastolic dysfunction. The next step is to estimate LAP, and here we rely on the E to A ratio and these other signals that we talked about, the 3 signals in the previous slide, in addition to pulmonary veins with the ratio of flow during systole to flow during diastole in hearts with depressed ejection fraction. Some examples: this is a patient with shortness of breath, clinical findings consistent with HFpEF. You see restrictive filling, low annular velocities, high TR velocity. If that's what we have, that is sort of straightforward, not particularly challenging. We have all the signals. Let's look at a more subtle case. This was a patient with shortness of breath, history of sarcoid heart disease, sarcoidosis. And if you look at the mitral inflow, there it is, annular velocities. LA looks big without any measurement. TR looks incomplete, and these are the values. If you look at the algorithm, we say the E to E prime is increased, the septal velocity is reduced, LA volume index is increased. So we have 3 signals, but all of them tell us that there is diastolic dysfunction. We go to estimate LAP, and we are in that group, a ratio that is more than 0.8 but less than 2, and we have 3 signals to look at here. We don't have a complete TR, but both E to E prime ratio and LA maximum volume index are abnormal. telling us that LAP is elevated with 2 positive signals. And given that middle range for the E to A ratio, we say the patient has grade 2 diastolic dysfunction. That's the nice wedge pressure recording I was referring to earlier. You see clear A and V waves. The mean pressure is in the high 20s, confirming that the echocardiographic estimation or assessment of filling pressures was accurate. Sometimes we do diastolic stress test. We go through the rationale for that. Some patients who have heart failure preserved ejection fraction can have a normal left atrial pressure at rest. But when they exercise, their LAP increases, as in the example I showed you early on in that presentation. And they get short of breath. So we want to uncover what happens to the LAP with exercise, and that's why we do that test. If a patient has an elevated LAP already at baseline, not a good idea to exercise them. It can go further up and they can go into pulmonary edema. So we do not recommend diastolic stress test for these cases. We like to acquire the TR jet in addition to the E to E prime ratio. Why? Because up to 30% of patients with normal LAP with exercise can have a ratio that is increased, but the real wedge pressure is not elevated. To avoid these false positive calls, we want to see that E to E prime goes up along with the TR peak velocity. That's the first publication on the diastolic stress test from the Mayo Clinic, taken from a patient with hypertrophic cardiomyopathy, non-obstructive. We see the aortic pressures, ventricular pressure, LAP. With exercise, mean LAP almost doubles from 17 to 31. You see large V waves here because of abnormally increased LA stiffness. We'll talk about LA stiffness shortly. If you look at the mitral E, it goes up, the annular E prime stays reduced, and so the E to E prime ratio goes up, capturing what happens in the pressures. That's a larger study, a validation study looking at the E to E prime ratio against LV diastolic pressure during exercise. And you see a significant association, rather similar to what you see at baseline. If you're looking for a more recent study, this is from the Mayo Clinic, looking at the septal and lateral E to E prime ratio at baseline, at low level exercise, 20 watts, and at peak exercise. And you can see a significant association between the E to E prime ratio at rest, low level exercise, peak exercise, and the wedge pressure, rather similar for the septal and lateral sides. These were not patients with segmental dysfunction. Notice that the percent of cases with not accessible or not measurable signals is not inconsequential. Part of the reason is if you're trying to record at peak exercise, faster heart rate, there may be some merging. Another reason is these were supine patients in the cath lab, so not positioned in the best way to increase the yield of these signals. The guidelines from the American Society of Echo and the European Association of Cardiovascular Imaging recognizes the importance of the diastolic stress tests, specifically in that group of patients who have a normal LAP at baseline but who are symptomatic. And this is another opportunity also to look at segmental function with exercise, because many risk factors for heart failure preserved EF also put these patients at risk for coronary artery disease. The supine bike is the best tool that allows you to look at both segmental function and filling pressures. Example from a patient here with exercise at baseline, normal PA systolic pressure, E to E prime ratio, as you see, impaired relaxation pattern. Now that changes to pseudo-normal, the hint of a beginning of an L wave, and markedly increased E to E prime ratio. If you look at the peak TR velocity is approaching 4, that's sort of the perfect example, if you would, for a positive diastolic stress test. To give you an idea for how these echocardiographic approaches compare to clinical assessment, this was a multi-center study for 50 patients comparing clinical and echocardiographic assessment of filling pressures. The clinicians relied on the clinical exam findings that are usually specific but not sensitive, the chest X-ray findings, as well as natriuretic peptides. You see the accuracy is 72% versus 87%. If we look at the group of patients with preserved ejection fraction, here it's a decent subset, 241 cases, it's 84 versus 64%. Clearly 16% missed, and there is room for improvement. So let's talk about some points that are relevant to the assessment of diastolic function. Many times people get confused how good of an agreement it is between different observers. To give you a background, if you look at the kappa statistics, this is sort of facts. A fair agreement is in the range of 0.21 to 0.4, moderate up to 0.6, and then more than 0.61 is substantial, more than 0.8 or 0.8 to 1 is perfect. So we took a group of cases, about 50 cases, and we asked different physicians of different experience to look at them, including members with expertise in diastolic function. And you see here that there was almost perfect agreement between them. You can say these are the experts. That's what we see. How about trainees with advanced cardiovascular imaging training? It was even better, 0.96. If you go to practicing echocardiographers who are not as expert, if you would, and not as familiar with the guidelines, perhaps applications compared to that expert group, they still have substantial agreement. And also if you go to cardiovascular trainees from these labs, very decent agreement between them. So the agreement is decent in applying the guidelines. Further, when you look at diastolic function grade and its association with clinical outcome, be it the combination of death and heart failure hospitalization, particularly heart failure hospitalization, you see a nice grading from normal to grade 3 diastolic dysfunction. It is important to look at diastolic function and to compare it with previous studies. We tend to compare ejection fraction or aortic stenosis severity between one study and the previous study. It is also good to do the same for diastolic function assessment. Progression of diastolic dysfunction is associated with a greater prevalence of heart failure or incidence of heart failure down the line, as opposed to individuals whose diastolic function does not deteriorate. Some other indices that have been looked at, diastolic strain rate. So here we're getting signals from the myocardium, the deformation, and then how fast that deformation occurs during diastole, during isovolumic relaxation and early diastole. That strain rate signal during isovolumic relaxation has nice relation with the time constant of LV relaxation as well as negative dPdt that I showed you in earlier studies. The same significant association with the time constant in humans. And that's an example from a patient with aortic stenosis where you compare to a normal subject. The normal subject has a nicely preserved strain rate during isovolumic relaxation, about 0.6, but a very slow strain rate during isovolumic relaxation in that patient with AS and diastolic dysfunction. Because we're getting the signals from the ventricle, they are not affected by annular or valvular disease. We get them during isovolumic relaxation, a time when there is really no transmitral gradient because the mitral valve is closed. We get it from all cardiac segments in the ventricle. It's truly a global index, and unlike velocity deformation, takes into account the length of the segment before deformation sets in. And similar to the E to E prime ratio, we can use the strain rate here. The units will be centimeters, and it relates directly to left atrial pressure. That was applied recently by our group in heart transplant recipients, and you see a significant correlation between wedge pressure and that signal. In comparison, the early diastolic signal is not that tightly associated with the time constant of LV relaxation in patients, wide scatter as you see here, and has an inverse relation with wedge pressure, but again, wide scatter that would not allow it to be used by itself. The main limitation for looking at these is they are high quality signals. We need good visualization for the myocardium. It needs experience in acquisition and analysis, certainly more time, and if you have a fast heart rate, lower frame rate, you cannot do them. How about PA diastolic pressure? We rely on PA diastolic pressure for two reasons. Part of it is the question of pulmonary hypertension, but part of it also is that in the absence of pulmonary vascular disease, the PA diastolic pressure is very close to the left atrial pressure. So if I'm looking at a patient with cardiac disease and I see a high PA diastolic pressure, then the odds are high that LAP is elevated. As in this example, if you do the modified Bernoulli without adding any RAP, you know that the LAP is at least 16 millimeters mercury. Patients with volume overload status, be it normal EF or reduced EF, 70% of the time will have both pressures, mean right atrial pressure and wedge pressure, elevated. But 30% it will not. And so if you're looking at a right atrial pressure in somebody who's, say, short of breath with signs of volume overload, odds are high that the wedge pressure is elevated. How do we get to RAP? Of course, if they are in the ICU, they have a catheter. You have that, but if not, then we rely on echocardiographic assessments. That's an example, pressure tracings for the wedge pressure and RAP from a patient with HFpEF where you see both pressures elevated. The left atrium is a big tool for us. And with diastolic dysfunction, LA volumes increase. And the largest volumes are in patients with the most advanced grades of diastolic dysfunction. The top that you see here is the maximum LA volume index. And that was the focus for many years when we talk about LA. But we can also look at the rate of change of volume or a surrogate of that LA strain. So we have the reservoir strain at the end systole. Then we have the atrial contractile or pump strain at end diastole. The difference between them is the Conduit strain. And what happens is with diastolic dysfunction, we said the volumes go up, but what happens to the strain goes in the opposite direction. It becomes reduced. The lowest LA reservoir strain occurs in patients with grade 3 diastolic dysfunction, as you see on that slide. And so some investigators have tried to associate it with LV EDP and with the mean wedge pressure. That's the reservoir strain, and you see a significant association. You can also see a good degree of scatter, meaning you can see wide variations in LAP and yet the same LA reservoir strain value. And the accuracy is better in patients with depressed ejection fraction and is much less if the EF is preserved. And in the group of patients where global strain is 18% or above, this LA reservoir strain is not associated or has no significant relation with LAP. This is a meta-analysis Dr. Khan did with me. He did the analysis. I just added my name. And you see the dots here signifying the size of the studies. The size of patients included in the studies, the larger the dot, the more the patients. And basically, if you look at normal LVEF cases, there is no significant association between LA reservoir strain and LV filling pressures. This is also has been reported by our group for patients with severe MR, particularly primary mitral regurg. As opposed to strain, stiffness is a more promising index, and stiffness is a ratio of pressure to volume. So you can use E to E prime as a surrogate of pressure, and you can use the LA reservoir strain as a surrogate for the change of volume. And the stiffer the atrium, the higher the PA pressures. That's not surprising. These are measurements obtained invasively. You see similar relations if you do it non-invasively. Also, stiffness is abnormally, of the LA is abnormally elevated with heart failure preserved EF. That was a very decent metric in this small study of 20-some cases with heart failure preserved EF. And this is a larger series from the Mayo Clinic where the area under the curve was largest for the metric of LA distensibility, which is the reverse of LA stiffness. You may say, how good is echo in detecting changes in filling pressures? And let's compare it to something. To compare it to something, we looked at the natural log of brain natriuretic peptide, and you see here no significant association. BMP was not able to detect changes, whereas the E to E prime ratio did well. Of course, it's a small sample, and many of these were patients with cardiac disease. If you look at the early mitral E to E prime at the septal and lateral sides, In patients with EF of at least 50%, the lateral ratio tends to do somewhat better, but both were less accurate than in patients with depressed EF. This is an interesting study that looked at the ability of echo to track real changes in mean left atrial pressure using a transducer that was implanted in the left atrium. You see a very large area under the curve for the average E to E prime ratio with the cutoff of 14. That was selected in the guidelines having an area under the curve of 0.94. That shows you examples with individual data points, what happened to the ratio versus what happened to the actual LAP, and you see nice tracking on an individual case-by-case basis. If you go to patients with, this is an older term, diastolic heart failure, it's really heart failure preserved EF, E to E prime ratio on the lateral side of at least 8 had a very decent sensitivity and specificity of 83 and 92%. There was an interest in using E prime to A prime ratio of less than 1 that did somewhat less accuracy, but overall an acceptable performance. I want to talk about some new things that are now available. We'll go through it quickly. One of these is shear wave propagation velocity. So we'll say what these are, what are their determinants, how they are measured, and do they really characterize diastolic functions. So shear waves are vibrations. Some of them naturally occur by closure of aortic and mitral valves. They propagate through the myocardium. To measure them, you need a very high frame rate imaging. Because the velocity is related to the square root of the shear modulus divided by the square root of the density, and because the shear modulus is determined by stiffness, when you see a high velocity, it signifies high myocardial stiffness. Another approach has been the extrinsically generated shear waves. Here what is done is you use a short push of focused ultrasound with a phased array transducer producing what is called acoustic radiation force. That then induces shear waves with the frequency in the kilohertz range. And again, the same principles apply. And if we're interested in the shear modulus, then you can see that it is directly related to the velocity squared multiplied by the density. The frame rate that you need here is 5,000 frames per second, so it's not available in the commercial ultrasound systems yet. And typically the velocity is measured in the short axis that shows the anterior septum. Showing you examples here, we are interested in that blue zone with the dotted line. With age, you see some increase in the shear velocity, but you see a very high shear velocity signifying high myocardial stiffness in the patient with cardiac amyloidosis, whether you look at the natural shear waves produced by mitral valve closure or by aortic valve closure. That shows the velocity going higher with the more advanced grades of diastolic dysfunction with significant association with the E to E prime ratio. And that's an actual correlation between the shear wave velocity and the wedge pressure in a group of heart transplant recipients, 52 patients, showing a significant association, albeit as you see some degree of scatter. The main limitation is that these velocities do depend on wall thickness and loading conditions, not just the intrinsic myocardial stiffness. At the present time, they are measured only in the septum, and so if you're looking at segmental dysfunction or segmental hypertrophy, you have to ask the question, is what I am measuring reflective of the whole ventricle or not? There are other concerns. We'll skip over these. Quickly, machine learning is a tool that has been applied to the study of diastolic function, and it's based on algorithms that can learn from data without relying on rule-based programming. Unlike the hierarchy that I described to you in grading diastolic function, this one collects the data, then groups the patients based on findings that they share together. There is no specific order in which it will place these patients, and that shows you how that approach compared with the Doppler-derived E to E prime ratio, both measured by echocardiography as well with the actual and predicted wedge pressure. Also, that approach was associated with clinical events, and I will skip these for the sake of time. And this is recent data with using a deep neural network showing that LV diastolic function as graded by machine learning was able to identify patients with worse outcomes from the TopCat trial. This was work from Dr. Sengupta and his group published 2 years ago. I know this is echocardiography, and CMR is a comer to this field. CMR also has a lot of data that is very useful. This is from a nice review. I recommend you read it. It's nicely written by Dr. Shamsi Pasha and Dr. Deepan Shah. It talks about structural abnormalities that CMR can draw your attention to. In addition, CMR can also measure velocities, though this is not routinely done. And so finally, when we look at diastolic function, we need to look at the clinical context. We need to look at the heart rate and the blood pressure. We need to look at the 2D data, volumes, mass, index, ejection fraction, LV, global longitudinal strain. Look at the signals that you acquire and their quality. You should record pulmonary veins. If needed, we take into account right atrial pressure, pulmonary regurg signal, LA strain. And then apply some common sense and scrutinize what you have to the clinical situation presented. If we end up with a situation where we cannot answer the question, say pressures are normal at rest, and this patient may still have heart failure, preserved EF, then we recommend a diastolic stress test, or they can go straight to cath, and certainly you can do their pressures by cath at rest and with exercise. Thank you. Yeah.